And now I'm going to my subject, which is hyperthermia in Poland, environment and studies. If you look at Poland in general, this is a kind of square of 700 kilometers or 500 kilometers like this. If you look at the locations of the installations, there are several whole body hyperthermia installations. Now we can see that in some parts of Poland they are unavailable. They can be listed directly. These are Eratherm and HT systems, 3000. If you look at deep and superficial hyperthermia, it's well, a little bit more widely distributed. I made a color code for the distributors, so we can see that 4 different distributors of the systems. And actually, Warsaw is the capital of hyperthermia for Poland, not only due to this Congress, but also to the number of capabilities which we have. So these are Celsius machine, BSD 2000, EH 2000, 3000, and for superficial, BSD 500 is the most popular one. Again, if you look at the institutions which has all capabilities mentioned here, despite whole body hyperthermia, Centrum Oncology, where we meet tomorrow, has 3 machines. HIPEC is becoming more and more popular in terms of medical applications, with first randomized data published just recently. As you can see, there are many, or even much too much, centers doing HIPEC. Probably we would like them to cooperate more closely. What actually happened with reimbursement of HIPEC from May last year? It's not very, how to say, it's well paid, but still it's good that it covers the costs. At that moment, it's clear that academic centers will be more interested than private hospitals in doing HIPEC, if it's just on the cost level, excluding any complications. Because if complications appears, then you are definitely under budget with doing HIPEC in Poland. First studies were initiated. In autumn, there will be hands-on meeting in Gdańsk. There are protocol writing meetings held now biannually, because the group chaired by Tomasz Jastrzębski is very, very active. They use the structures of Polish Society of Surgical Oncology, since usually surgeons are mostly in charge of qualification of the patients. But definitely for Polish Society of Hyperthermia, I would like to mention that this is the group which you should cooperate closely. They put all information on a website, which is easily to recognize. It's simply hypec.pl. And there are the contacts for the patients and for the centers to refer the cases. 600 procedures already performed and documented in Poland with HIPEC. Probably much more were performed, but were not tracked for the outcomes. Okay, and the studies in hyperthermia, which comes from Poland. A few years back, Agnieszka Żółciak-Siwińska from Marszałkowska-Curie has first published a study on combination of brachytherapy with interstitial hyperthermia and local advanced cervical cancer, which showed the feasibility to perform randomized study, which was published in so-called GRID journal. It was a phase 3 study performed by the team which you can see here. So not only radiation oncologists, but also statisticians mentioned on the page here. These were more than 220 patients. After exclusion of the patients who could not be treated or were excluded due to not meeting the inclusion criteria, it was more or less 100 versus 100 patient study, which was quite well balanced in terms of FIGO stage, meaning the stage of the disease, with involvement of the para-aortic lymph nodes, which is major limitation for usage of brachytherapy, age of the patients, and some other cofactors which are of prognostic nature. Probably the hyperthermia in Poland would evolve more rapidly if the outcomes would be different. We are very unhappy to see that the experimental arm is below the brachytherapy, and probably this study, which brought a lot of attention in Poland, made also a lot of negative publicity for using hyperthermia locally. And this was the moment where most of the hyperthermia in clinical use was stopped in our institution. Up to the moment when ESHO founded installation of BSD 2000, this is how it looked like when the machine appeared. And this is how it looks like now. You can see it tomorrow. So it's in old simulatory room in RT department. So very close to the Liniacs, so you can easily combine hyperthermia with radiotherapy at that moment. I would say that it's modern hyperthermia facility. So again, thank you, ESHO. And using that machine, we've been planning and starting some studies. The first of studies comes from the sarcoma team, led by Professor Rutkowski. The sub-investigator running most activities here is Mateusz Pałek. The idea behind that is that we have unresectable or borderline unresectable sarcomas which are treated with conventionally fractionated radiotherapy, which takes 5 weeks to be delivered. If still tumor is unresectable, there is a sequential boost which prolongs the treatment up to even 7 weeks. So such treatment is suboptimal for frail patients or for patients with many comorbidities, which leads them to short expected lifespan. So in that study, having the information from the other observations that you can use hypofractionated radiotherapy in pre-op setting in this patient, the patients with histological diagnosis of soft tissue sarcomas with no medical and technical contraindications for deep hyperthermia, if they are either over 70 or prognosed to have 10 years survival below 40%, according to Charlson scale, or if they have medical contraindications for surgery, which makes preoperative standard treatment non-feasible in them, or they have diagnosis of either chemo or radiotherapy resistant sarcomas, they can be enrolled to that treatment. Oh, sorry, this is Polish. I pasted the wrong graph here. So the patients, if they meet criteria for enrollment, within 2 weeks are planned to receive radiotherapy, which is 10 fractions per 3.25 grays, which is delivered within 2 weeks. And they have hyperthermia sessions twice per week, so 4 sessions during that time. After 6 weeks rest, there is reassessment at CT or MRI, If at reassessment the tumor is still unresectable, there is a second session of RT, which is 4 days per 4 grays, with hyperthermia twice. If they are deemed to be resectable and the patient is medically resectable, the patients are directed to operation and there will be a follow-up. So this is a small phase 2 study with primary outcome of toxicity, focusing on local control also. So as I mentioned to you, the study is ongoing since the installation was completed installation of the system was completed something like 1 year ago. Of enrolled 8 patients, there was 1 patient with grade 3 toxicity, which was diarrhea related with the high dose of radiotherapy in rectal field. there was no excessive skin or other toxicity in organs at risk. And there is a strong signal for activity, especially in this chemo-resistant G1 sarcomas. So very interesting field for further investigation. More data with the show of the plans, RT plans, will be prepared by Mateusz and presented tomorrow. The second protocol developed but which has not started yet is hyperthermia in locally advanced pancreatic cancer. This comes with the story of the HEAT study. As you know, it was also presented. The HEAT study focused on adjuvant treatment in pancreatic cancer, where we combined the standard post-operative chemotherapy with hyperthermia, and the study was stopped due to introduction of new, very active chemotherapy, which was FOLFIRINOX. We all were thought that FOLFIRINOX may be too toxic, but at the standard practice, it showed that it's feasible to do FOLFIRINOX in adjuvant. And how about unresectable cancers, again, locally advanced? If the pancreatic cancer is resectable, it's clear that there is a surgery as a first step. If it's borderline resectable, we use chemotherapy or sometimes chemoradiation before treatment and go for surgery. We have also data from Netherlands from last year that neoadjuvant chemoradiation will give us the survival benefit. So for these borderline cancers, the standard now will be chemoradiation and chemotherapy preoperatively. Of course, if you have locally advanced pancreatic cancer, the treatment for you is palliative chemotherapy. And the problem of pancreatic cancer in general is that pancreatic field is quite densely packed with all structures. So beside pancreas, there are several arteries and veins which are unresectable. On CT scan, it's also good to locate that pancreatic field is quite deeply located within the central part of abdomen. On CT scan, you can see that the tumor can infiltrate here the portal vein, or can be very close to also the arteries and veins in the SMV is, sorry, SMA. I recall Polish name, and I recall superior mesenteric artery or superior mesenteric veins, which are usually deemed as unresectable tumor if there is infiltration. At that moment, the tumors cannot be easily resected, which recalls the situation of advanced soft tissue sarcoma. Probably in many cases you've seen that. So in these cases, according to the recommendations, the standard care is 6 months of gemcitabine, which is usually not very active. It shows the partial response in something like 7% of the patient. So there is a need for new kind of treatments. Probably FOLFIRINOX can be recognized as an additional standard of care. So can we combine FOLFIRINOX from medical point of view, biological point of view, with hyperthermia? Well, there is alkylating agents inside. So induction of BRCA phenotype, if we believe in that activity of hyperthermia, can be here very useful. Especially that we have the data for oxaliplatin that hyperthermia induced the cell toxicity. Probably you all know that landmark paper about BRCA phenotype, and probably you know that in several diseases the BRCA lack of the BRCA2 or BRCA1 was associated with the excessive activity of platinum agents, which are one of the elements of FOLFIRINOX. So the aim of the study is to combine modified FOLFIRINOX regimen with hyperthermia in order to boost the response in locally advanced pancreatic cancer. After screening, The plan is to perform 4 cycles of M-FOLFIRINOX. I will show you on the next slide how it's planned, and then continue their assessment after these 4 cycles. If the patient will be assessed as unresectable, he or she will continue the palliative treatment. And if the resectability tends to appear, we'll proceed with regular surgery. FOLFIRINOX includes three elements, actually 4 elements, but 3 of these are cytotoxics. It's protracted infusion of 5-FU, which takes 48 hours, 46 hours. Oxaliplatin, which you usually deliver in 2 hours infusion. Irinotecan, which takes 1.5 hours. Leucovorin, which is used on day 1, is a kind of activator of 5-FU. It has no direct anti-tumor effect. So you plan to use irinotecan with leucovorin at the day 1, along with the start of 5-FU, and then oxaliplatin delivered at day 2 and day 3 during hyperthermia sessions within 1 hour slots. I would say that it's quite elegant, especially if you use single-use infusers for 5-FU. At that moment, you don't need to put the patient in bed rest for the whole 48 hours because patient can easily move. This is a kind of device which includes 250 milliliters of saline with the drug. At that moment, it's easily convertible from the bed, chemotherapy bed, to the place where hyperthermia can be delivered. So this is feasible only if you combine this within single-use infusers. We do modifications of regular FOLFIRINOX to simply cut the toxicity. Okay, the risk of hypersensitivity of oxaliplatin, since this drug is quite hypersensitive, and we would like not to have intensive care unit transfer directly from hyperthermia. So this is the problem. We'll need to use more premedication with steroids. The response assessment will be performed by RECIST criteria, and RECIST will be a primary endpoint here. Due to the limitations in time, I need to skip some more slides here. The sample size is feasible if you see several responses in group of 20-something patients. We assess that, excluding dropouts, we need to focus on 24 patients. So, summarizing, hyperthermia in Poland has a long history from the first published, unfortunately, negative studies published 7 and 8 years ago. And with HIPEC reimbursement from May, we expect that this will boost scientific activities with the strong group of Tomasz Jastrzębski. And there is no special reimbursement for hyperthermia sessions. Probably this would also boost some other activities. At that moment, there is a very hard political situation, since majority of hyperthermia sessions are delivered as a kind of alternative medicine at private insurance for heavily refractory patients combining with different chemo regimens. Probably, especially in Germany, you know what I mean. But we are very happy that academic trials are starting, and more will appear soon. Thank you.
Lucien, thank you very much for that interesting overview about the activities in your country. Maybe I can start with the first question. This negative study for brachytherapy, did the authors analyze reasons for that negative study? Maybe the temperature was too low, or different groups of patients?
I would say that probably both, because it was not revealed the reasons for that, but there is I would say that the locally advanced disease which involved the lymph nodes treated with brachytherapy, which has very local activity, is slightly opposite what we understand should be done now. So This can be one reason, simply combination with teleradiotherapy and brachytherapy on top maybe would be more suitable for that clinical setting. I would say that we don't have data about quality assurance. It was done in the best way as could be. Probably you should ask the authors for that. But I have the feeling that maybe also the study ended 7-8 years ago. So the study started with 200 patients several years ago earlier. So at that moment, the data on quality assurance and possibility to measure the temperature with functional methods was simply absent.
Are there other questions from the audience?
Just a small remark, if this could be of help. We had a similar situation in Switzerland a few years ago, and we have now from the Ministry of Health 4 indications which are indefinitely reimbursed based on evidence, and 7 which are temporarily reimbursed based on evidence and running clinical trials. If you want, happy to provide this information.
Thank you. It will be very valuable.
I have another question.
Okay.
In Germany, there were a lot of discussions about the temperature measurement in the heat study for pancreatic cancer. So should we use tumor catheters, tumor-related catheters, or no catheters? At the end, we have decided not to use invasive thermometry for this indication. How do you handle that?
Actually, this was the major reason why patients didn't want to go on heat study in Poland. When we suggested them that the catheter will be, there was a suggestion that it should be in the vesicum and also in the rectum, yes? Yeah. Early on study, yeah. And patient didn't like that. Okay. Hyperthermia looks quite elegant, and at that moment it stops to be elegant. So after first few patients, offering them also this procedure, neither me or my sub-investigators were very happy that there was a suggestion that we should not place it. Okay. At that moment, the accrual went a little bit up with preference of the patients. Well, we need functional data for that. To skip any measurement, we should have simply other and learning curve also and the other capabilities rather than putting the measuring catheter in bladder or in rectum.
Okay. One question.
I think combining hyperthermia with radiotherapy is a quite difficult thing to understand, and it all depends what is the goal of the hyperthermia. If you come in with your radiotherapy, you try to kill the tumor cells, but you have also a major influence on the tumor microenvironment, and you wipe out a lot of immune environment as well. If then the hyperthermia tries to change the tumor-host interaction and not only try to extra kill the tumor cell, then the combination with radiotherapy will never work, because your radiotherapy will be much more stronger. However, if you place your hyperthermia outside the context of radiotherapy, trying to modify the tumor microenvironment as primary goal, my guess is that it will work. In relation of this perspective, your curve that you have showed was event-free or progression-free survival. What was the overall survival? Maybe that was a little bit better or not?
No. There was no effect on overall survival. The curve looked similar. I presented. Was it worse? Was it still a little bit worse? But due to the time of observation, the curve tended to flip-flop a little bit on the end. But the primary outcome was disease-free, because this was recognized as a mostly local treatment. if you discuss the sarcoma trial, it's hypofractionated radiotherapy. Actually, all the basic rules of radiotherapy does not apply there. We don't know what are the rules which are behind higher fractions. At first part, this is 3.25 grays. At second part, it's 4 grays per fraction. It's probably related more with the boost of the immune antigens rather than cell killing. So this is very short effect with longer rest for immune activity. We don't know what's the conditions there and if the same conditions apply with the microenvironment as you mentioned right now.
Okay, we
need to go on.
Yeah.
With
the next talk will be given by Zhang. Focus.